So, why is an anesthesiologist up here talking about primary care? I guess I'm a member of Docs for Patient Care, which is an organization, really a grassroots organization of doctors that saw what was happening with the Affordable Care Act and thought there'd probably be a better way forward. And that's how we got here. Hey, thanks for the tweet. Just saw that. So I'm busy on Twitter, so you can follow me because I tweet very often about healthcare and health-related things at MadMD. You'll see me there. So I don't want to be too redundant, but I want to talk about a little bit about how we got here. And for all of us, I'm 52 years old now. I was born in '62. Really, the government got involved in healthcare. Really about 1965, and we all have these stories before that about, geez, I remember I paid my doctor $5 for a physical exam, or 3 dozen eggs, and I got it done. And that's because the government was not involved in healthcare before that time. So that was why healthcare was cheaper. And once the government got involved in 1965, here's what's happened. Now we can get a third party involved in the machine of healthcare, and it gets busier and busier and more expensive and more costly. And I really kind of discovered this. I've been involved in the administration of healthcare at a large health system just outside of Ann Arbor, and I've been doing this since '95. And when I heard some of the pharmacists saying, "Well, that's 400%," and I said, "What do you mean 400%?" "Well, it's a 400% markup for the cost of that drug that we pass on to the patient." I said, 400%? He goes, "That's typical for the industry." I said, "Really? 400%? That's when I knew something was a little amiss here. When on the inside, this is kind of how these organizations run, and I said, there's got to be a better way to do this. And so this is kind of how we got to 818% growth in the cost and delivery of healthcare. Next slide, please. There we go. You already saw this. Yeah, if you put nurses there, nurses would be here too. So the providers, the frontline delivery, PAs as well. It takes a lot of people to deliver healthcare, but it doesn't take that many people to deliver healthcare. Okay, so there's a lot of mouths to feed. Now, John talked great about, let's go back right there, thank you, on the patient-centered medical home. And you've probably heard this in the literature right now. It's really a hot topic. Everybody's talking about it. This is the ideal third-party managed patient-centered medical home. You see there's a lot of stuff here. There's quality and safety, and they've got some good things, don't get me wrong. Some of this stuff makes sense, but there's a lot of stuff because they want to make it expensive. Really, they're adding on a lot of features. And in fact, like some of these features, electronic medical records, if this was really a patient-centered product, you'd be able to take it home with you. It'd be on your cell phone. So you had all your medical information with you at all times. So when you go to CVS Caremark, or you go to Walgreens, you can say, yeah, these are the drugs I'm taking. Do any of them interact with the new drug they just prescribed me? That's how it should really work. If it's truly patient-centered, that's exactly how the technology would work. And there are products that are coming to market that are going to do that very thing. But you don't need these folks to do that and keep it within their silos that you can't have access to. And that's what these folks want to do. And they mostly want to measure things and pay for their accountants and what have you to again, ginny up their own costs and keep all the money within them. I don't know if you've heard of the Accountable Care Organization, but basically that whole concept is essentially an HMO where, yes, we get your money and we got it, we'll take care of it, we'll funnel it back to ourselves, and we'll incur the cost savings and pass along to ourselves. You never see it again. That's the Accountable Care Organization model, and I'd be happy to challenge anybody that thinks otherwise. But that's exactly how these kind of models work. The money's never passed back on to the patient. So the patient is not incentivized to be well or have wellness or kind of fight for their own health. And they need to be incentivized to do that and engaged in their own care. This does not do that at all. And again, you can see this over here. What do they call it? Oh, I'm sorry. Population management. What does that mean? That's rationing healthcare. That is saying we need to carefully, what do they call it? Steward their resources. That's what they're teaching now in medical school. No longer the Hippocratic Oath. You're not talking about what my role is to the patient, it's my role to the population as a whole. What that gives us is a dystopian era where, you know, again, we're telling people that they can't have care when they, in fact, it's their money. Okay? Next slide. Boom. Here's our saving grace right here. This is going to bust us out of third-party managed healthcare, and it's going to happen fairly quickly because math really works and it's very, very efficient. And everybody's talking about, gosh, the deductibles are crazy. Yeah, they're dramatic. We've gone from $50 copays to $5,000 deductibles. The math has changed by an order of magnitude for most of us now. And thankfully, the insurance companies were fairly greedy about this, and because that's going to bust us out of this whole third-party problem that we have in our healthcare. And again, this has gone on for 2 generations. So if you look at directly purchased healthcare, well over 50%, they're already in these high deductible health plans. This is all on the private sector side. Employer-based healthcare, this is the Fords, the Quicken Loans, all the folks around here, fortunately, state of Michigan, a lot of self-insured companies, and the big 3 and all their suppliers. Many folks now have credit cards to spend money on healthcare, and they've got a health savings account and these high deductible health plans. Well, what's happening in the public sector side? Next slide, please. We jumped ahead, I think. Well, this is more on that. No, next slide, we could jump forward. Look at what's happening in the Medicaid ACA plans. These are those plans that the government was so highly touting. What do they do to deductibles? So basically what we're talking about here is an individual that might make $30,000 a year, and he's getting subsidized health care right now if King Burwell stays. But if that goes away, we're going to be in a different situation. He gets subsidized health care for his insurance, but not his deductible, or her deductible. So imagine if you make $30,000 a year, and now you need a knee arthroscopy. How quickly is that going to be eaten up with a knee scope? Very, very quickly. So you don't even hear anybody talking about these aspects of it. But I can tell you that these folks too, God bless them, they need health care as well, right? And we can all be in this predicament, right? We're fortunate that we may not be now. We might be in the private sector side. That's 49% of the market. But we might get into this space at times. And we need to take care of these folks. But they too are in this deductible situation. So now again, they're going to be shopping for health care and looking, what are my other options for health care? I'm in a group, we have 105 doctors in my private group. Many of us buy our prescriptions in Canada. We all know where we go in Canada to get our prescriptions. This is how the market's going to behave because it saves us money. We all save about 60% off our prescriptions by going to Canada for them. Okay? Can I say that a little bit? That's happening in the marketplace. It's going to happen, and it's going to sweep all. It's going to affect both primary care and surgical care where I work. Next slide. So the wonderful thing about this, for patients, these deductibles equal leverage. Now we really are responding to you. We have to respond to you because you know what? The first part of coverage, all this cost sharing starts with you guys. So that's what makes, for me, it makes healthcare extremely exciting right now. And models like direct primary care are very exciting to me because of this reason alone. And people will start to understand this very, very quickly when they start getting sold on this patient-centered medical home setting. Realize how it really isn't about them at all, as much as they like to tell you it is. But if you can drive the bus and you have the money, you can push this marketplace. And that's exactly what the industry's starting to realize. So what's happening? Next slide, Kyle. Thanks. These folks are not dumb. They're realizing that there's a whole retail healthcare marketplace that's developing now. And they're going to get on the front of this. CVS Caremark that just sold or quit selling cigarettes, 2 years ago? Because they wanted to get into this space. They're entering into it rapidly. Walgreens is behind them slightly, but just watch out for Walmart. Walmart's going to be very innovative on how they deliver, basic care services like immunizations and screening tests and what have you. They're going to do that very, very well, and God bless them. That's exactly what we need. We need more competition in the marketplace. Next slide. So now you're seeing all this transparency that's coming in the marketplace. You can get an app called Healthcare Blue Book, which actually Priority Health, which is based out of Grand Rapids, Michigan, is part owner in this product. They can show you what your overall cost should be for an ambulatory surgery center to get a knee arthroscopy, about $4,200. I can tell you, if you call my hospital right now, they won't tell you an answer, and they'll get back to you in about 2 weeks, and they'll say it's about $15,000. That's what they'll tell you. Okay? But that's what you really should be expecting to pay, and you should ask these questions before you even go to a hospital. For anything you do, even elective surgery, all of it, ask the question. Now we're also bundling prices. There's my buddy Keith Smith at Surgery Center of Oklahoma. You can go to his site and you can actually look at all his pricing on his website. Oklahoma's a little ahead of us because they've got a lot of self-insured employers that are in the oil industry in both Texas and Oklahoma. So they were early on to this health savings account stuff. The math worked for them to send people up to Oklahoma City, get this done instead of going to their local hospital for 3 times that to get those surgeries done. There's a great little YouTube video on Surgery Center in Oklahoma. I think it's Doctors versus Obamacare if you want to. 2 minutes? Am I almost done?
Yeah, you're actually
I'm
over.
Next slide, last one. So here's where, I really think direct primary care is the most innovative model that I've seen yet in all this transition. I think it's exactly what we need because now we can actually hire our fiduciary, if you will, for healthcare. Somebody that's going to actually really look out for us. And now they're contracted by me and nobody else. There's no intermediary between me and them. And I need them to keep tabs on me and coach me. What's the most cost-effective way to do this? Maybe, hey, Matt, get on a plane and go down to Surgery Center of Oklahoma. Or here's where you buy that expensive on-patent drug, and here's the Canadian pharmacy that you do that at. So you literally are getting a coach for your own healthcare, which is, I think, the correct model going forward. Okay? I'll answer questions at the end. Thanks.
I have about 15 slides here. I'm going to try to stay out of the projector. I have about 15 slides here. I'm going to go through very quickly, so hopefully you have questions that we can ask at the end. But my overall theme of the presentation is what are the things that we need to do to make direct primary care popular in Michigan? What do we need to do to bring it here so everyone can enjoy it? And so we can all have better health, better healthcare experience, and lower cost. So next slide. We're there. Okay. Healthcare is killing the United States. It makes up about 20% of our economy right now and growing. And healthcare is a big reason why GM went bankrupt, a big reason why the city of Detroit went bankrupt, and who knows who else. And right now in the state of Michigan, 40% of the state of Michigan's budget goes towards healthcare. So if we want more money towards roads, we want more money in the schools, where's the bucket that we can reduce to put more money into roads and schools? The next slide 3. So how did we get here? Where did this cost come from? We already talked about the growth in administrative roles. But more than 75% of our healthcare costs are due to chronic conditions, things like diabetes, high blood pressure, arthritis, heart disease. Now, we can talk about where these diseases come from, but the fact is we all have them. And in order for them to be treated, they need care, coaching, and a relationship. And it's up to primary care to manage these conditions. If we manage them effectively and control them effectively, we can effectively cure them in a sense, or at least give the patient a healthy lifestyle where they won't end up with a heart attack or a stroke. So we can talk about the innovative ways to do heart surgery, or you see the commercials about new lasers and robotic surgery at the hospitals, but the fact is you need care, empathy, and coaching to manage these conditions effectively, and that's primary care. Old-time, relationship-based medicine. That's what it's going to take. And other countries have already figured this out, and that's one reason why they spend half as much as we do on care. You can talk about single payer if you want, but the fact is they've organized their system around primary care, and they emphasize primary care, and it leads to good outcomes for their citizens. So in our current system, how is primary care practiced today? When you go to your doctor, how is it practiced today? Well, physicians only get paid if they see patients face-to-face in their office. They don't get paid for phone calls or emails. Now, your personal doctor might do email, they might take phone calls, and understand that they simply do that out of the kindness of their heart. They cannot do that every day for every person, every patient. And also, for every primary care physician, we've gone over this, 40 to 60% of their overhead is related to servicing insurance, Medicare, and Medicaid. So 40 to 60 cents of every dollar goes to paying off and making the middleman happy. So as a primary care physician, you need to see 25 to 40 patients a day just to cover that overhead and to make money. So what happens when a patient comes in with chronic conditions? Well, the physician, to generalize, the physician will look at his watch and think about the full waiting room he has and think, how can I get this patient out of my office as soon as possible by providing some relatively decent amount of care? So they'll go through their computer and they'll check a bunch of boxes and they'll refer them to many specialists, many specialists, and then they'll tell that patient to come back in 6 months. So the patient will go see all the specialists, end up on 20 different medications, have no idea how to properly control their condition, and ultimately end up with a stroke or a heart attack, all those high cost things that we're trying to avoid. So next slide 5. So we need to change this. We need to flip the model on its head. Our current system is on the, you're seeing on the left. That's our current system where we spend a ton of money on specialty care and administrative cost, and very little on primary care. About 5% of our healthcare costs is spent on primary care right now. So we need to flip that, where we're spending and concentrating a lot more on primary care. And direct primary care is a great way to do that. So why direct primary care? Why is it a great way to move from the left to the right? Well, it removes that face-to-face visit requirement in order to get paid. And it completely gets rid of that insurance overhead that I talked about before. So it's a direct relationship between the patient and the physician. And the physician is finally free to provide care in whatever way they see fit, best for the patient, however much time that might take, and their job is to just do things well. So we've already talked about PCMH, patient-centered medical home. I'm sure you go to your local doctor, there's a PCMH sign on their door. Now PCMH is an attempt by insurance companies to move from the left to the right. But it doesn't get rid of the face-to-face visit requirement. And from an insurance overhead standpoint, it in fact increases the overhead for the physician. So it in fact doesn't solve anything. So slide 6. But direct primary care, if you look at the big providers of direct primary care in the country, if you want to go home and Google anything, Google Q-Lions, Google IOR Health, Google Dr. Blanchard. These are successful primary care practices that have been practicing direct primary care for a long period of time, and they're achieving 20% reduction in costs. Now there's no other innovation in healthcare that is showing these kinds of results. Not PCMH, not accountable care organizations, ACOs, not HMOs. Nothing is achieving these types of results. Under Obamacare, the goal is to try to bend the curve, to just slow the rate of healthcare increase. To say go from 10% increase to 5%. They would consider that a success. These organizations are declining costs by 20%. And so what do we need to do to bring them to Michigan? Well, they're not here right now. They're in Seattle, they're in Massachusetts, they're in other states. How do we make it happen in Michigan? And first off, change is hard. No matter how good of an idea it is, old habits die hard. And unfortunately in Michigan we have very, very strong hospital systems. Now they do some good work, but they have tremendous power in the state. And I thought this quote was very fitting in terms of what we're up against. So slide 8. So in order to bring direct primary care and really have it flourish in Michigan, what can we do? Well, first and foremost, we need to make it easy. We need to make it easy for everyone. And we need to make it easy for 3 main parties: physicians, primary care physicians. Primary care physicians are internal medicine physicians, family medicine physicians, and pediatric physicians. Those are the three main groups of primary care. We need to make it easy for them, we need to make it easy for patients, and we need to make it easy for employers, because the fact is employers are the big spenders on healthcare. That's where most of us get our health insurance from. So slide 9. But we have a problem. We have a chicken and egg problem. So what came first, the chicken or the egg? The fact is, patients can't take advantage of direct primary care if there aren't any physicians out there practicing direct primary care. Physicians won't practice direct primary care if patients don't demand it. Employers aren't going to put direct primary care in place for their employees if they're not educated about it, if there's not a wide distribution of physicians where their employees can go and see. So we can't sit here and just wait for it to happen. We have to start, and everyone here is starting to build either the chicken or egg and try to attack some level of problem. But we could use your help on making this happen. So I'm going to go through the three different groups here on the next few slides, and then I'll wrap it up. So the next page on what needs to happen for it to be easy for patients to take advantage of direct primary care. It needs to be easily purchased through your doctor, or easily purchased through the way you normally get your health insurance. Is that through an employer? Is it through Medicare, Medicaid? Is it through an insurance exchange? How do you get it right now? We need direct primary care to be able to tie into that. Also, direct primary care needs to be able to be paid for with health savings accounts and be used or count against your deductible in your insurance policy. Right now, you cannot use health savings accounts to pay for direct primary care, and it cannot count against your deductible. Why? You can ask the IRS. But we need Congress to change this. Unfortunately, we have allies on both sides of the aisle. This is a bipartisan effort to try to change this. We have Bill Cassidy, Senator in Louisiana, Marco Rubio in Florida, Orrin Hatch in Utah, and then on the Democrat side, we have Patty Murray and Maria Cantwell in Washington that are all pushing the IRS to try to change this rule. But you can call your representatives and try to get them to change it as well. So next slide on the employers. What do we need to make it easy for them? Well, most important thing is we need a wide network of physicians willing to practice direct primary care. Because if an employer is located here in Northville, they'll have employees that live in South Lyon, Ann Arbor, Royal Oak, Troy, Livonia, all over the place. So we need physicians that are located in those various places that they can tie into. And then for physicians on slide 12, what do we need for them? Well, physicians have a hard time. Physicians right now could say to their existing patient panel, you no longer can see me unless you pay me a monthly fee. And that would work out great for the physicians. It would work out great for those patients that pay them the monthly fee. But what about all the patients that don't pay them the fee? So from a physician standpoint, they're a little worried about potentially perceiving to be alienating their patients. So we need some way to help them incrementally transition, either through what John is doing with Henry Ford, or another aspect of helping physicians transition to this route. And also there's legal issues. So one issue that was removed, Senator Colbeck removed that issue. There's also the issues with HSA and deductibles, but also we need Medicare rules removed. But what can you do as you leave here? What are the three things that you can do? Well, you can get your representatives in Washington to change the HSA rules. You can start to encourage your employer to look into direct primary care, and you can start to encourage your physician to look at direct primary care as well. And as we're all working on developing some aspects of the chicken and egg, Forthright Health very soon will announce a network of direct primary care providers, nearly 100 physicians located in the red dots you can see here, which will all be practicing direct primary care. And we're going to begin by contracting directly with employers. And then to finish up, we can hopefully get the full package, and then we'll have better healthcare experience and low costs for all of us. So please get in touch with me on the last slide. Free to talk anytime. Thanks.
I want to introduce you to Kenneth give you an opportunity to talk about some, a little bit different perspective on the healthcare market here in Michigan.
First of all, thank you very much for the opportunity to be with you today. I would make the observation that all of this is about leadership. And leadership requires leaders. And that means everybody here can be a leader. You just have to inform yourself and then act like a leader. And so that's where it really all begins. Everybody in front of you today is really somebody who stepped out and said, hey, wait a minute, I want to be part of the answer to this big problem. So that's my first comment. Now, I'm not a doctor, but I work with almost all the major healthcare systems in the United States, from the East Coast to the West Coast to here in Michigan and the Midwest on some basis. We have clients that are employers within the Fortune 100, the Fortune 1000. We also have clients that are small employers, 100 employees, 500 employees. So every day my team in Wilson Partners is out there trying to consult employers about how to optimize the opportunity for their employees to be healthy, right? The best medical plan for every employer is one of two things. One, there's no employees under it, so there's no risk of financial loss. Or two, everybody's healthy and nobody gets sick, right? We have employers spending a lot of money, right? I have clients that spend $1 billion a year in their health care spend for their employees. Guess what? It's on the 10% that are sick. 10% that are sick. It's not on the 90% of people that are going to work every day and producing the value of that business. And yet we're not investing in the health and well-being of that population of people in anywhere close to the same level as we're taking care of the 10% are sick. Now, I'm not saying we don't take care of the 10% that are sick. I'm saying we need to take care of the 90% of the people that are not sick, that we can prevent getting sick or being able to maintain their health and well-being and be an asset to the business. So my first slide here is, and I'm going to try to speed through so we can get a little time here back, is that we understand improved employee health and well-being as a strategic asset of the business. So if I go into the CEO of an organization, I don't care how big it is, he owns two things, and she only owns two things. Right? They own the value of the business, what's the valuation of the business, what's the stock worth, and what's the culture of that business. They don't own the top line, that's sales, right, and marketing. They need to bring in the revenue, they need to bring in the customers. And the CFO, he owns the bottom line, she owns the bottom line. The CEO owns culture and value. Right? What's going to define the culture of any human organization more than the definition of human caring, i.e. love? How am I going to care for you? That's what the CEO owns, culture. And healthcare defines culture. That's what the president understands. If he can define healthcare, he can define the culture. He can define how you relate to each other and care for each other. So the first thing to make clear is that healthcare is a strategic asset of the business. That's important. Second is that employees' most valuable asset they possess is in fact their health and well-being. You can have all the money in the world, but when you become disabled, you are disabled. You no longer can go to that house down in Florida. You can't go up to Harbor Springs anymore, right? Because you are now disabled, not able, which is health and well-being. You're disabled. So one thing we got to begin to do is make sure that our people, you included, all understand that every day you wake up, your health is your most valuable asset. Now that's going to tell you